So today I was asked to present on the vascular anatomy of the brain and the spine. I must admit that this is a really huge topic that can take either 30 minutes or even days just to study on the vascular anatomy. However, I'll try to synthesize as much as I can. So, as we all know, the brain is richly vascularized and represents around 15 to 20% of the cardiac output. So, it is being vascularized by the arterial supply is being done by two main circuits. We have an anterior circuit, which depends on the internal carotid artery, and a posterior circuit, which depends on the vertebral artery, which comes from the subclavian artery. So, talking about the carotid artery, let's go directly. So, the carotid, we have to know that the anterior and the posterior circuits will anastomose to form what we call the circle of Willis. The circle of Willis. So the carotid artery will take its nest from the bifurcation of the common carotid artery, usually at the level of C3, C4, or C4, C5 cervical spine. And I'm sorry, you can't see what I'm showing, right? Hello?
I'm sharing the screen now, it's fine.
No, actually, I want to share the screen because I have other things to show while sharing the screen. So I thought I was sharing.
Oh, it wasn't showing.
Yeah. Okay, sure. Can I just do?
Yeah.
Okay, screen. Start. Is it okay? Is this okay?
Yeah,
Hello?
it is.
Okay, great.
Yes.
So it usually takes, like I said, its nest at the bifurcation of the common carotid artery, usually at the level of C3, C4, or C4, C5. So it varies. At its nest, it bulges to form what we call the carotid sinus. Carotid sinus, which is usually very sensitive to baroreceptors. While it goes superiorly or causes superiorly, it causes through the, let me put the picture, I'm sorry. It causes through the carotid shed, and usually it is accompanied with. So usually it is next to the vagal nerve or the internal jugular vein and the sympathetic nerves. So we will use the classification of the Cincinnati classification, which is the latest classification in 1996, to divide it into 7 segments. We have C1, which really represents the cervical segment. Like I said, which one's really next to the vagal nerve, the vagal nerve, the internal jugular vein, or the internal jugular vein and the sympathetic nerves. So it ends at the level of its entry into the carotid canal in the petrous bone, or in the petrous bone, where you can see it take a sharp curve anteriorly and then superior-medially. It ends at the external ring of the foramen lacerum, where it takes now the name C3, which is the lacerum segment. The lacerum segment would then end at the level of the petrolingual ligament, where it comes out just into the intracranially, forming the C4, giving out the C4 segment. The C4 segment, which is also known as the cavernous segment. Which is also known as the cavernous segment. You have to note that why these segments goes up, they will give perforating branches or they will give lateral collateral branches, amongst which at the level of C2, it will give the carotido-tympanic artery, which will anastomose with the branch of the sinomastoid artery of the mark, which comes from maxillary artery. This is important. It's important for us to note that there's a rich anastomotic relationship between the different arteries, whether extra coming from the external carotid artery and the internal carotid artery. This is just to maintain the debit or the cerebral perfusion, rate. Then the C2 also gives what we call the Vizian artery. The Vizian artery, which also anastomoses with the greater palatine artery. At the level of the cavernous, that's at its outing from at the petrolingual ligament, it forms the cavernous segment. The cavernous segment usually supplies the dura. Through an anastomosis with the posterior ethmoidal artery. It also vascularizes the trigeminal ganglion. It also vascularizes the two dural venous sinuses, that's the different petrous sinuses. And he also gives the inferior hypophyseal artery, which will vascularize the neural hypophysis or the posterior pituitary gland. And then it curves sharply at the level of the cavernous and sharply superior medially and enters the external dural ring and forms the C5. The C5 segment is the kleiner segment, which usually does not give branches. And then at its extent, the C5 will pass through the posterior clinoid process and then will curve anteriorly through the anterior clinoid process and will give the C6 segment. The C6 segment represents the ophthalmic segment or the supraclinoid segment. The supraclinoid segment will give out branches such as the superior hypophyseal artery, which will be responsible to feed the anterior pituitary gland and also the infundibulum. It also gives out the ophthalmic artery, who will be responsible for the vascularization of the orbit. And then it curves upwards and forms the C7, which is the communicating segment. The communicating segment, which is giving out branches. The first branch that will give is the posterior communicating artery at its posterior medial part, which will cause posteriorly to anastomose with the posterior cerebral artery from the basilar bifurcation. It then gives the anterior choroidal artery. The anterior choroidal artery, which has a very complex course inwards to vascularize at the end the choroid plexus in the lateral ventricle. At its stem, its final beautification is made out of the ACA as we know, and the MCA and the MCA. So what is really relevant? What's really relevant here is that there's at the C4, yes, at the cavernous, at the cavernous portion of the cavernous segment of carotid artery, there's also the outcome of the meningeal, the anterior meningeal the middle meningeal artery, which richly anastomoses with posterior structures. So we'll see that later. So let's talk about ACA first. The ACA is made up of depends on the class, on different classifications. They are put classified into 4. There are some who remain at 3, and there are some who put it in 5. I think the latest is the 5 segmentations. We have the A1, which is pre-communicating. The A1 will travel through the longitudinal fissure, and it starts at the ACA, that's at the bifurcation at the level of the carotid artery, and will end at the junction with the anterior communicating artery. Usually, when it crosses the A1 segment will let out perforating arteries, amongst which we have the largest, which is the Hubner artery. I think we have it somewhere here. Somewhere here, yeah. The Hubner artery, which is inconstant. It's not always at A1 that this artery comes from. It can also come at A sometime, or at the junction between both of them. And we give out also some more smaller perforating arteries, which are responsible, which will pass through the anterior perforating substance to vascularize some inner structures such as the hypothalamus, part of the midbrain, and the diencephalon. Then you have the posterior communicating segment. The posterior communicating segment starts at its junction with the A, and then will give branches. Will end at the branching of this artery at the genu of the corpus callosum to give out what we call the callosum marginal artery. Let me show you from this. Okay, this is it. So at this branch, it will curve at the you will give the callosomarginal artery that is then at the bifurcation of the callosomarginal artery with the pericallous artery. This is the pericallous artery, this is the callosomarginal artery. The callosomarginal artery will slip or will lie just above the gyrus rectus, which is the cingulate gyrus, which is here, and why the pericallosal artery, which usually represents the A3 to A5 segments, will lie just above the corpus callosum. So the A3 segment will cause from this bifurcation to the genu of the corpus callosum, and the A4 segment will do same. The A5 segment is usually the terminal segment, which will cause continuously and posteriorly will anastomose with segments from the posterior cerebral artery, that's from which vascularize the calcarine sulcus, the calcarine gyrus in general. So what's important to say about the anterior cerebral artery is that it's a common site of aneurysm, particularly the A, the anterior communicating artery. And in most studies, we found that an hypoplasia of one of the A1 segments of the anterior cerebral artery, usually there is a greater chance because there will be an increase in the debit, in the cardiac debit, in the cardiac pressure, on the walls of the anterior communicating artery. Hence, a common location of and of aneurysms. So let's talk about the middle cerebral artery. The middle cerebral artery represents the largest vessels, let me just say, or the largest termination of the internal carotid artery, and it will give rise to some classified into 5, but some remain into four or 5 different segments, depending on the classification that you use. The M1 segment usually originates at the bifurcation, originates at the MCA, that's the bifurcation of the ICA, and will end at and let me show you. Okay, this is it. It usually originates at the ICA bifurcations and usually end at its entry into the sylvian fissure. So this is the first part of the MCA, the M1. The M1 also gives perforating branches, also called the sphenoidal segment. It gives out perforating branches which passes through the same anterior perforating substance responsible of the vascularization, or what we call close striated arteries, which are responsible for the vascularization of the globus pallidum, the part of the thalamus, and etc. Then we have the M2 segment. The M2 segment will rise from its entry into the sylvian fissure. Let me show you here. Yeah, no, this is not a good image. So this is a better image. So it will rise from this entry into the sylvian fissure up to the lumen insulae. So it will be responsible. You'll be responsible for the vascularization of, usually it takes part in the vascularization of the internal capsule, which passes just by part of the insulae and other structures just nearby the operculum. As it bifurcates into the opercular segment of the insula, it will take another name, another segment, or the opercular segment, where some can consider the whole junction. Here, some consider no, not here. This one. Okay, let me see. Okay, so as it causes under the, if you like this M1 segment, as it causes in the insular operculum, some consider the whole, we call it book, the whole segment inside the operculum to be an M3, and some divide from between ascending and descending and consider it M3 or M4. It depends on which classification you find. And then the last branches are the cortical branches of the which are M5, which are at the number of 12. Here I saw the cited 10, but it goes up to 12. One of the 12, which is very important, is the temporo-occipital artery, which is the largest of the cortical segment of the middle cerebral artery, which is usually used to carry out what we call anastomosis. I think the last one that I saw was an anastomosis between the middle meningeal artery and this temporo-occipital artery, This was to vascularize or to promote, there was a scalp necrosis. So they wanted to vascularize that zone, like to promote wound healing of that part of the scalp after a neuronal approach. So they use this bypass. The surgeon here used that by the bypass between these two arteries to promote vascularization of the skin scalp at that level. So the next we were talking about is the posterior cerebral artery. No, the posterior circuit. The posterior circuit originates from. Okay. The posterior circuit originates from the vertebral arteries, which both come from the subclavian artery, as we all know. And progressively, the first branches that it gives out is the posterior inferior cerebellar artery, which sometimes will also give out the posterior spinal arteries, but sometimes this posterior spinal arteries could also come from the vertebral arteries. And then the second branch it gives out is the anterior spinal, the anterior spinal arteries, followed by the anterior-inferior cerebellar artery. So the vertebral artery is made up of 4 portions. We have the cervical portions and the intracranial portions. The cervical portion starts at the level of C6, at the level of the tubercle, the Chassaignac tubercle, where it courses upwards. And then at the level of C2, it takes a sharp turn that forms the V2 segment to enter and goes a sharp turn that's supremedially to enter the foramen magnum, just next to the spinal cord. As it enters, it gives these different branches, like I stated earlier. The anterior spinal artery and the posterior spinal arteries, which will be responsible for the vascularization of the upper part of the spinal cord. You have the pica. The pica will be responsible for the vascularization of the lower parts of the posterior fossa. You have the medulla oblongata. It also vascularizes the inferior parts of the cerebellar artery, of the cerebellum. Inferior parts of the cerebellum. It will then join together to form the level of the ponto medullary junction to form the basilar artery, a unique artery, which will gradually give out the ICA. The ICA, which takes a sharp turn behind and causes really next to the cochleovestibulofacial bundle, and is usually responsible when there's when it is too close to this structure, or if there's an aneurysm at this junction that's really next to the internal auditory canal, where this bundle enters the internal canal. It usually causes symptoms such as
hemifacial spasm.
Yes, exactly. Hemifacial spasms. I think the last one that we operated was not a week ago, and the patient had hemifacial spasm due to this contact. And we did a Janetta, that's a micro decompression of the ICA from the bundle. And I think post-operatively, the consequence was she left from hemifacial spasm, which is usually very unpleasant situation for the patient and very painful, to a peripheric facial paralysis, with vestibular syndromes on that side. And then it will, the basilar artery will continue its median and the upward course and superior course to why it moves or why it goes, why it courses superiorly. It will give out other branches, perforating branches, and lateral collateral branches, amongst which we have the pons branches to vascularize the pons through which it is, through which it courses. And it also gives another collateral branch, which is the superior cerebellar artery. The superior cerebellar artery, which has a very keen relationship with the posterior cerebral artery. This keen relationship is that as it courses up, sometimes you might find the posterior cerebellar artery, which originates from P1. There's the segment P1 of the posterior cerebral artery, and you can find it even on P2. The superior cerebral artery will vascularize mostly the part of the pons, but will cause posteriorly to vascularize also the vermis and the different lateral parts of the different lateral hemispheres of the cerebellum. It when it in their course between the PCA and the SCA, there is the third motor nerve which they sandwich. Wow, that's the name. Which they sandwich. So an aneurysm of the
lecture depuis laptop G4 G-Vivier 37.
So an aneurysm, either at the level of the SCA, which is really rare, or at the level of P1, which will usually give a paralysis of the third motor nerve. But laterally, they also sandwich the fourth nerve. That's another thing that laterally. Here we don't have a full image, unfortunately. And oh my God, I'm sorry about that.
Sorry, while you're searching for that, let me just make a quick important contribution at this point. At the free tentorial, when the PCOM is passing through the ambient cistern as it goes parallel with the tentorial edge, and then it follows the third cranial nerve as it also goes continually. So an aneurysm of the PCOM can actually cause compression of the third cranial nerve. That's what gives us that classical description of arrangement of fibers within the third cranial nerve that talks about the non-pupil sparing and the pupil sparing third cranial nerve palsy, where of course now that brings us to the knowledge where we know that the fibers responsible for the motor fibers and the parasympathetic fiber arrangement. So it said that the motor fibers, I think they are peripherally arranged, while the parasympathetic fibers are centrally arranged. So when you have the pupil sparing, I think is when the compression is from without. Right? No, non-pupil sparing is when the compression is from without, and pupil sparing, please correct me if I'm wrong, but I think that's how it is. If the motor fibers are peripherally arranged, it means that when the compression is from outside, it affects, so it gives a non-pupil sparing type. But when it's a vascular injury to the vasa nervorum, which will result, of course, more to central injury and then subsequent peripheral affectation, would be more of not a pupil sparing type. I don't know if I'm right, but someone can correct me. Thank you.
Okay. So fine. Thank you so much. Finally, we will end with the bifurcation of the basilar artery, which is the posterior cerebral artery, which is divided into 4 segments. I have not found any other classification, but it still remains these 4. We have the pre-communicating segment. That's this segment which is just before the anastomosis of the anterior and the posterior circuits. And the pre-communicating segments will give different branches, amongst which we have the thalamo-perforating branches. We also have the medial posterior choroidal artery, which will vascularize which will partly vascularize the posterior portion of the choroid plexus at the level of V3 and the lateral ventricles. And we also have the quadrigeminal plate artery, which causes in the quadrigeminal system and will participate in the vascularization of deep-seated structures. We have like the reticular formation. Part of the structure, we have the reticular formation, the pallidum. And after that, we have, sorry, I didn't show that. We don't have all the pictures in Greenberg, unfortunately. But here, I think you can find greater pictures. Okay, this is it. So the second segment is what we call the crural segment. The crural or ambient segment, which is divided into 2. We have an anterior and a posterior part. The anterior part is the crural segment, also known as the peduncular segment. It will be responsible for the vascularization of the cerebral peduncles, the substantia nigra around, and the substantia nigra around. So let me just say thrombosis or an ischemia of the P2A segment will lead usually will be responsible of a patient who will present like Parkinson-like syndrome. Let me state it like that, Parkinson-like syndrome. As for the P2P is a very important artery. The posterior part of the P2 segment usually travels in the ambient system laterally, as you can see, and will be responsible for the arterial vascularization of mainly the hippocampus. Hence, the hippocampus, hence an injury or ischemia of this P2P segment will be responsible for memory loss. We will have memory issues related to an ischemia of the hippocampus homolaterally. But we also have to note that apart from memory loss or the incapacity to form episodic memory or incapacity of newly adding, like we call it anterograde memory, as it's in English too. Anterograde memory, that the patient will not have the capacity. That's there's an ischemia on both sides. The patient will not have the capacity of learning new or gaining new attributes or learning new things. Like he will have a memory loss in the anterograde form. That's the principal. Let me just say, vascularization area of the P2P. Then we have the P3. The P3 is just after the P2P. The P3 is the quadrigeminal segment, which travels through as the name says, travels through the quadrigeminal systems laterally between the lateral midbrain and the parahippocampal and dentate gyrus. You'll be responsible of the vascularization partly take part in the vascularization of the mammillary bodies. We partly take part in the vascularization of the mammillary bodies medially. And then causes the final segment P4 is usually cortical. P3 usually ends at the level of the calcarine sulcus, and then P4 then takes the vascularization of the calcarine gyrus. Hence, an ischemia of the P4 will usually lead to visual impairment. Visual impairment. Okay. Now, if we want to talk about the supratentorial drainage of the brain. The supratentorial drainage of the brain is made up of different groups of drainage systems. We have the superior sagittal group. Usually, the superior sagittal group is this group of veins, whether they come from the cortical or cortical aspect, that's the cortical drainage. There are this group of veins which will drain into the superior sagittal sinus, as you can see here. And part of these veins are made up of, we can find the different anastomotic veins, amongst which we have the superior anastomotic vein, usually at the frontoparietal level, and we have also the inferior anastomotic vein. The superior anastomotic vein is initially called Trollard vein. Now we are trying to remove names from anatomic structures, and we have the inferior anastomotic veins, also called the vein of Labbé. Usually, when you go for a surgery, when you expose the temporal lobe, you can clearly see that the surgeon will try as much as possible to preserve these anastomotic veins. This is because these veins helps in the drainage of that's in linking deep-seated veins, like deep-seated veins with the superior sagittal sinus. With the superior sagittal sinus, we have the inferior anastomotic vein or vein of Labbé, which will link the veins from the Sylvian fissure, which will drain veins from the Sylvian fissure and connect them to the superior sagittal sinus. And we have the superior anastomotic vein of Trollard, which will link veins from the medial portion, like the cingulate gyrus, corpus callosum, part of the corpus callosum, or the cingulate gyrus to the superior sagittal sinus. It's really important to talk about veins because veins we don't usually take into account. We think veins are not usually very important, but it's very important because a venous impact is usually more dangerous and less reversible than an arterial impact. Hence, in most of surgeries, they usually plan the venous to preserve the veins than even preserving some of the arteries. Where like Dr. Abbas told us once, yes, part of, as you can see, the drainage of the 2/3 anterior part of the 1/3 anterior part of the superior sagittal sinus is not that important. Hence, it could be sacrificed for some surgeries, but care should be taken not to sacrifice either this vein, the superior anastomotic vein, or the inferior anastomotic vein. So the superior sagittal vein will drain into the turbula of heterophyly. The tubular heterophyly is composed of a drainage coming from the deep-seated inferior sagittal sinus, which will drain also into the straight sinus. And we also have the different thalamus-related veins, which will drain into the galen, which will drain into the galen, what's called the galen vein, the inferior, the internal cerebral vein, sorry. The internal cerebral veins and the inferior sagittal sinus will drain into the straight sinus, which will drain into the torcular heterophyly. The torcular heterophyly also drains the part of the inferior, the posterior fossa veins, amongst which you have the occipital vein, which very drains here. And after that, will continue drain into the transverse sinus, then the sigmoid sinus, and then to the IVG. What's important here is, let's talk about the great vein of Galen. The great vein of Galen is usually important in approaches to the pineal region. Before choosing an approach, either an interhemispheric occipital approach or a superior supratentorial and supratentorial supratentorial inferior occipital approach, or supracerebellar and inferior tentorial approach. You usually have to study the pattern of the Galen vein around the tumor, that's the pineal tumor, which is usually stated here. So either you have the tumor which pushes the Galen vein upwards, then you can use the supracerebellar infratentorial approach. Or if it pushes the vein laterally or inferiorly, you can pass either interhemispheric occipital approach to remove the tumor. So there's some considerations to take into account. Now, as for the torcular heterophyly, it's important because usually when we have median suboccipital approaches towards posterior fossa tumors, you have to, there are some measurements already calculated. I think it's 1.6 centimeters from the external. Usually this zone corresponds to the external occipital protuberance, but sometimes it might vary. And it varies interpersonal varies. There's a great variability interpersonally. So some, like here, what they do is that they prefer studying the image per patient before addressing this zone. Like, you have to do everything to be underneath the torcular heterophyly, because the drainage is so important that a tear of the torcular heterophyly, even though you can manage, it is preferable not to have this tear. Then another important fact about this is, I want to say here that I don't know why, but I doubt on this. I doubt on this image, but okay. This image, I don't know if it is really correct anatomically.
I guess what's confusing you, it's the way the transverse sinus moves. That's
Yes.
why it's a bit bent, so that it will look like it's coming from the side. So it's not a true lateral view. It's like an oblique view.
Okay.
Yeah. So you're looking at it.
I think so.
Yeah. So that's why it's like that. So ideally, if you're looking at it straight up, you're not supposed to see the transverse sinus.
No, you're not supposed to.
Yeah. So I guess that's what.
Yeah. So another important group we have is the sphenoidal group. The sphenoidal group of veins are these veins who will drain into the what you call into into how do you call this? Into the cavernous sinus. Cavernous sinus, which whose name comes from the cavernous corpus of the penis from its name. It's a really rich parasagittal drainage, which parasagittal sphenoidal drainage, which not only acts as a main protector for most of for part of the ICA, like we saw the C5, the C4 segment of the PA of the ICA, but also it lets the cause of different nerves, like you can see. Laterally, we have the abducens, we have the V1 and V2 of the trigeminal nerves, and we also have the oculomotor nerve, that's the 3. It's also very important to note this because this is a frequent axis for the management of aneurysms, which are usually located in this area, and there are safe zones. I think one day one of us posted the different triangles, safe triangles that we could pass through to attain different aneurysms at the base skull. I think here is the triangle, the Parkinson triangle, which is very famous, where you can pass through safely without injuring nerves to clip an aneurysms at this level. It's important to note that nowadays aneurysms is gradually being taken. I don't know what is this in your centers, but it is gradually being switched to radiologists for endovascular treatment. But I think the anatomy is important for the neurosurgeon. So, but in Côte d'Ivoire, it's the neurosurgeon who does the endovascular treatment. So I guess it's important. So talking about the posterior venous fossa anatomy, the posterior venous fossa anatomy, like I said, is just the same part of the supratentorial veins, like the great cerebral vein of Galen, will participate in the drainage of the posterior fossa. We have the precentral cerebellar vein. Precentral cerebellar vein, usually which vascularizes the anterior part of the cerebellum. We have the posterior mesencephalic vein, like its name says, vascularizes the posterior part of the mesencephalon. It drains, the posterior part of the mesencephalon. Lateral, we have the tuberculum sellae. But like I said earlier, the Galen vein, the importance of the Galen vein comes from these different structures which drain into it, amongst which we have internal cerebral veins and we have posterior cerebral veins. Hence, during a surgery for a pineal pituitary lesion, it's important to preserve this Galen vein, because if we have an ischemia or a thrombosis of this vein, we can see that we can have a posterior fossa infarct, and that would be really, it's really a huge damage for the patient. We usually come and then they are really post-symptomatic. We've talked about the torcular autophilia, the different part of the inferior hemispheric cerebellar veins, which would drain in the straight sinus, which drains in the torcular autophilia. The drainage system is really important, both superiorly and inferiorly, and posteriorly, excuse me. Oh my God, that's not okay. Let's not talk. Oh my God. Let's now talk about the spinal cord vascularization. Like I said earlier, the spinal cord vascularization, part of it comes from the vertebral artery, like we saw the anterior spinal artery, which comes from both vertebral artery anteriorly and then will join at the level of C2, C3 anteriorly, and causes in the anterior circles of the spinal cord. But this vascularization is not usually enough. Like only the vertebral artery cannot vascularize the whole of the spinal cord. Hence, they are usually supplemented by radiculomedullary arteries, which usually come from, for example, above underneath C3, they will get some help, that's some radiculomedullary artery from the deep cervical artery, for example, or the costocervical trunk. From C8, they will get supplements from the left, either from the left subclavian artery, or they will get help from the thyrocervical trunk. Then underneath C8, they get supplementations from the superior intercostal artery or the inferior intercostal artery, at the level which all comes from the aorta, from branches of the aorta or the arc of the aorta. At the level of, we have to note, at the level where there is the brachial plexus comes from, like segments where the brachial plexus comes from, they need usually important vascularization. Hence, at the level of the cervical region, that's between C4 and C8, we'll have supplements like it's like that. We will have supplements from this radiculomedullary artery, and another one is at the level of the thoracolumbar region, which one famous is the artery of Adam-Kivitz. The artery of Adam-Kivitz, which can either come from the lumbar artery, which comes directly from the descending aorta, or could come like this artery of Adam-Kivitz, in some cases will come directly or could be supplemented directly from the aorta or the inferior intercostal arteries. They are usually zones richly vascularized, but part of the spinal cord is really lowly vascularized. We have particularly the regions between T8 and T4, T8 and T3. Hence, the principle of, if you have a thoracic fracture, it is, we call it la loi de Tourien in French. It is the law of either you have a complete injury, like, and either you're ACIA A or you're ACIA E, because the vascularization is so poor here that usually the vascularization is so poor that there's no supplement enough for the spinal cord to survive the shock. We then have the posterior spinal arteries, the posterior spinal arteries, which either come, like I said, they can come from the vertebral arteries, but sometimes they come from the pica. And they are not median, they don't join, so they remain lateral, posteriorly, and will vascularize the whole of the spinal cord. There's a very nice and complex mechanism, anastomotic mechanisms, which divide then actually the vascularization of the spinal cord into an anterior vascularization, posterior, and we have the PL vascularization. The PL vascularization is this vascularization that comes from secondary arteries laterally, where the anterior or the posterior circulation cannot reach. So they will form some kind of complex anastomotic and I think here it is. Oh, yeah, this. So they'll form some kind of complex anastomosis between anterior and posterior vessels, rendering a complete vascularization of the spinal cord at each segment. I think here it's important for us to talk about the anterior radicular. There is part of the medullary arteries, the radiculomedullary arteries, which vascularize the dura mater. The dura mater is, as we know, one of the portions of the body which is sensitive, which is not only vascularized, but it's also innervated. Like it's the one of the painful. It's painful. It's painful. The dura is usually painful. Like it has pain receptors. So usually when you have when you go for a surgery, usually for example laminoplasty, after opening the dura, you do your maximum to preserve this artery, which usually comes from the posterior ganglion, which causes next to the posterior ganglion of the ganglion posterior. The posterior, which causes next to the posterior ganglion. You do everything not to go through lateral, because if you injure this artery, the patient may have as main complication a necrosis, not only of the necrosis, not only of the dura, and you might end with the CSF leak postoperatively. So it retards your management. As for the venous vascularization, you have to know that it's tributary to the arteries. It's not that famous. It's the same. It doesn't have. There are plexuses which do not have valves in general. We do not have his vena in general, and they are tributaries to the artery. I think that's all what I have to say for today.
So much. Thank you so much, Dr. Gomsi. Thank you very much. Beautiful presentation. Yeah, I don't know if you have any questions, contributions, and comments, so that we can quickly move to case-based discussion. Okay, so there are no contributions. I think, yeah, while discussing the venous drainage of the spinal cord, I think it's good to talk about the valveless vein of Batson, because of the important anatomical problems that maybe I should tell you. We all know it's a very important pathway for metastasis from the lumbosacral region or intra-abdominal pelvic pathology, spinal cord.
That's good.
And then also at the end of the spinal cord, at the level of the
Conus medullaris.
Yeah, conus medullaris. Yeah, there's this at vascular arcade. What's it called? Lazarus, right? Lazarus. Yeah, that's the encapsulation at the end of the conus. Yeah. Some important vessels to remember in the brain as arteries to remember. One is the recurrent artery of Hibner, that can originate either from the anterior communicating or from the junction or from the A1 segment. It's an important vessel not to forget, especially when you're doing anterior or anterior ACOM procedures, or you're going for tuberculum cellae or cellar meningiomas. It's important to remember it. So I think these are some of the few contributions I just wanted to make. There are many more, but there's also the artery of Pancarion or something like that. Yeah, Pacheron, yes. It's also important. It's a rare, it doesn't always occur, but when it occurs, it also has its own important clinical correlate. Then what's the other thing? I don't remember. But I think yeah, well, I think you did very beautiful justice to it. Microvascular decompression, yes. The other one is trigeminal neuralgia,
Yeah.
SCA, neuralgia. Yeah, so which presents with a classical tic doloro, painful shooting or stabbing hemifacial pain, which associated, which is usually comes in spasms, and it's interspersed by a period of not complete resolution, but downtimes, and then it gives a sinusoidal pattern, becomes high, and after some time it resolves, and then as associated triggers, either when the patient is chewing food or when there's a sudden emotional event can be triggered. Yeah, so those are just a few contributions I wanted to make. Thank you.
I just wanted to say that I think pedagogically, I think maybe next time if you can divide this into supratentorial vascularization, posterior fossa, and then spinal, it would be better because you can't say everything, and saying everything will be it is so interesting, each part, that you can't say everything, and I think rather we will gain if we divide these presentations into for everyone to at least partake.
Okay, I'll consider doing that in the next round of the Greenberg. I'll think about that.
Thank you.
Yeah, thank you. All right, I think that's all for Greenberg for tonight. Well done, everyone. Beautiful session. All right. Well, so I'll be stopping the recording now so that we can have a separate recording for this session. Then we'll go back. We'll go to the case-based discussion for tonight. Okay, thank you.